Hello, everyone, and welcome to APHA's weekly webinar addressing the COVID-19 crisis. This is an open forum for all of us in our profession to be able to have conversation around important issues and late-breaking issues related to COVID-19. This is our 11th week in action on this webinar. Many of you have joined us week in and week out, and we thank you for that. And we know that this is providing some valuable information to you because you keep coming back, and we appreciate that. I am Michael Hogue. I'm Dean and Professor of Pharmacy at Loma Linda University in California, and I'm the current president of the American Pharmacists Association. Welcome today. We've got a great program for you today because one of the topics that continually comes up is we know that our seniors are at a really high risk of morbidity and mortality related to COVID-19. So we thought what we would do today is hear from a couple of pharmacists who are actively engaged in providing care for senior populations from a little bit different perspectives. So it's exciting. Today we're going to have two folks joining us. First is Matt Osterhaus. Matt is a former president of APhA. He is the co-owner and manager of Osterhaus Pharmacy and M&M Care in Maquoketa, Iowa. He's a graduate from the University of Iowa's College of Pharmacy and has, as I said, has been a member of APHA's Board of Trustees and was the 159th president of APhA in 2014. Now, his practice in community pharmacy includes long-term care. He provides community pharmacy services, but he also consults with area long-term care facilities, does lots of specialty packaging and so forth in these facilities. Providing a little bit different perspective is Carrie Krebs. Dr. Krebs is a board-certified consultant pharmacist with Senior Care Pharmacy, which is an Alabama corporation. She's been there since 2006. She's very passionate about simplifying drug regimens for our seniors and looking out carefully for the homes that she provides consultant pharmacy services for, and really looks carefully at the issues that are going on with medication therapy. And both of these folks are going to provide you with great information about different things that we need to consider as pharmacists as we begin providing more care and as our country starts to reopen. Now, this week we will also be joined by Mitch Rothholz, the Chief Strategy Officer of APhA. Mitch is going to be sharing with us some late breaking news from the CDC regarding pharmacies, and I'm just going to leave it at that right now, but the CDC has released some new guidance for pharmacies, and it's something that you're not going to want to miss. We'll be covering that a little bit later in our program. This week, like every week, we're joined by two other rock stars within APHA's staff. First of all, Dan Zlot. Dr. Zlot is the Vice President for Professional Education at the American Pharmacists Association, and I would tell you that Dan has a 10-year history of working with the NIH in immunology and oncology, and so he really is here to answer your clinical questions if you have them about COVID drug therapies or other things related to COVID. So we'll take those questions today too. And Elisa Bernstein, our Senior Vice President for Pharmacy Practice and Government Affairs, who's had a 30-year career with the Food and Drug Administration, is an attorney herself and understands a lot of the legal aspects. And so if you have questions about laws and regulations related to COVID, today we'll take those questions so that Elisa can answer those and hopefully provide you guidance. Now, I want to kind of give you a little bit of an overview. We're going to go for about 20 minutes with Matt and Carrie in an interview style format where we'll ask some questions. If you have questions in your GoToWebinar control panel, you have the ability to type those questions in. We'd ask that you just go ahead and do that. As your questions come to your mind, go ahead and put them into the control panel. Also, just to let you know, we like to hear your voice. And so if you have a question, we'd love to be able to have you ask that question verbally. We'll call on you when it's time to do that. And in order for us to be able to do that effectively, if you've joined us today from a cell phone or a landline, you'll need to input your audio PIN now so that your phone line will be active when the APHA staff unmute your line. For those of you who are joining on computer audio, it's just a matter of clicking a button, obviously. So just to give you those pieces. Now, as always, we're recording today's webinar. It'll be posted within 24 hours at pharmacist.com in the COVID-19 resource pages, and so you'll be able to listen to that. And also, today's handout is available to you in the control panel, but it'll also be available to you at pharmacist.com. So with that, I'm going to ask Matt, Carrie, would you please join me on video? We want to get started and learning from your wisdom at this time. Welcome.
Thanks, Michael. Glad to join you.
Glad to be here.
All right, it's great to have you. Let's just dive right into long-term care facilities right away, because both of you are working with long-term care facilities. When long-term care facilities begin taking measures to mitigate the spread of COVID-19, how did your relationships with the facilities you work with change? I mean, were you treated as a healthcare provider or as a visitor, or, you know, how did that relationship change? And Carrie, I wonder, we'll start with you as a consultant pharmacist providing contracted service in, and then Matt, we'll want to hear your opinion as community pharmacist providing service in.
You know, for me, it was a very gradual change at the beginning of March because we tried to start doing things a little more remotely just to reduce our visits to our facilities. And then about the middle of March, we just shut the physical visits down as much as possible. So we did not want to expose ourselves to folks that might have been exposed to the virus in our facilities, but we also didn't want to bring any germs in from outside. So we started, you know, really keeping our relationships with those directors of nursing and our nursing staff. Everything kind of became digital. And so I feel like we've sort of been training for this for years, because we are able to do our jobs remotely as consultants if your facilities are set up on electronic medical records, and that's the big if. But we just really started using email, phone calls a lot. You know, we really had to strengthen our communications with them in digital formats.
Okay, Matt, what about your experience there?
Yeah, so similar timeline, Michael. The facilities were initially, you know, just doing temperature checks and things like that as we got into March. So we did our initial reviews and went up and kind of business as usual. But then when things closed down, you know, we pretty much, our delivery people don't go into the door. They leave things at the door. Our consultants, you know, are doing everything remotely, and there's a little challenge when as Carrie says, if you don't have full access to all the information electronically, it kind of becomes this back and forth with faxing and phone calls and things like that to get the information you need to do your consulting jobs. I consult for 4 different facilities, and we have other consultants on our staff that serve our other facilities. But it's, you know, all of them were a little different in the way they went about it. But I think when you talk about how are you treated, they still really look to us as being part of their team. So they were coming to us saying, here's what our company's saying we should do next. What do you think? And how do you think we should handle this medication-wise? And even, you know, how do you think we should handle this from a communication standpoint? So I think that it's one of the great things about consultant pharmacy and long-term care is that you really have this interactive piece between yourself, the facility, and the prescribers that are involved in that facility, the medical director. Everything kind of gets bounced off in a very collaborative way. So it's good to be a part of the team, but it's definitely a different piece when you don't have that full access to the information you're used to getting. And Carrie kind of alluded to it, the nurses that are seeing the patients that are right the direct care part, they provide us critical pieces of information for us to do our job better. And when you all of a sudden are only talking to the director, or that it just becomes a little more of a challenge. You have to do a little more digging to get to where you want to be, but the access and that teamwork is still there.
Yeah, well, challenging times for sure. And I wonder, Matt, you know, among the facilities that you provide care for, have you had any outbreaks of COVID-19, and have you been in the midst of having to provide care for patients with COVID-19?
We have not, Michael. We've been fortunate that you know, that everyone's taken infection control very seriously. You know, we're in a somewhat remote rural area, so we don't have the number of people milling around, but certainly have a few cases in the county, but have really had all of our facilities have managed to stay COVID free thus far as we know. There's not been a ton of testing done, but we've had some patients that developed symptoms and were tested, but have not had a positive yet. So we're fortunate from that standpoint.
Yeah, it sounds like it. Carrie, you're in an urban and suburban area of Alabama. Has your experience been different than Matt's?
I'm very envious of Matt's. My experience has been very different. I consult for 5 different facilities across the state of Alabama, and my facilities have been involved and exposed to COVID-19 from very different sides of the spectrum. We've had some facilities that have provided beds for patients to come and recover after they have tested positive for COVID-19, been in the hospital, and then tested negative. They have come to some of our facilities to recover. We've had some patients that have been moved from sister facilities into some of my facilities that I consult for, because they were having to move some patients around because of exposures in their home facility. And then unfortunately, I have one facility that had widespread COVID-19 virus, and it affected about 94% of the patients in that facility that tested positive. So we had a massive outbreak there.
Wow, and that's got to be trying from a pharmacist standpoint, and trying to manage medications and transitions of care. I'm certain that many of those patients transitioned out to the hospital, back to the facility. It sounds to me like that would be quite a challenge to manage the medication therapy of all of those patients. I wonder, Carrie, did you have any connectivity as a consultant pharmacist with the hospital pharmacist, or with the hospital where patients were being moved back and forth? Was there any interaction there?
There wasn't so much interaction, but there was a lot of me comparing the charts and doing the transition of care to check the transcription as our patients were coming back to us or coming to us from another facility or from a hospital. There was a lot of transcription checking and double checking to make sure that we were continuing medications they were on prior to going out to the hospital, making sure that we were continuing the orders from the hospital. I mean, it's the same thing that you do normally for any patient coming into a long-term care facility, but there was just so much back and forth, and there still is, that it just, I think I'm just being extra careful to make sure that nothing gets missed in the shuffle of the chaos of going between buildings and going between hospitals and long-term care facilities. It just, it was just a little more complicated than it normally is.
Yeah. Now, Matt, one of the things that we've heard a lot about on the national scene, and the CDC has reported, is that people are just, because of stay-at-home orders and because of the desire to try to prevent the spread of COVID, a lot of our seniors who have chronic underlying conditions like diabetes and hypertension, heart disease, may have not been seeking chronic care for those conditions during the last 3-month period of time. What have you and your pharmacists done to try to help address that? And what should the rest of us be thinking about relative to that, given that we're starting to become a little bit more open and people are milling about a bit more?
Yeah, I think, Michael, when you're asking we're asking citizens to isolate themselves to a degree and to really think about, not having social interaction that's unnecessary. The problem is that you can have a patient, and I would say this especially affects our senior patients, that maybe take it a step too far, and they don't want any interaction with anybody because they have this fear of the virus. So they don't communicate with their physician. They don't reach out to the pharmacist. They want to just do everything they can on their own and survive with as few number of people involved in their lives as they can. What we've tried to do is really be proactive with that. And in a case when we're talking about seniors that are living in the community versus the long-term care facility, a lot of those patients with chronic conditions, we have medication synchronization. So we actually make a phone call to them once a month and find out how they're doing, if there's been any changes in their medications, if they're ready for us to deliver another batch of medications to them. So we have that built into our workflow now to have that, which 5 years ago, 6 years ago, that wouldn't have been the case. So I think that's a real bonus from that standpoint. But we're trying to be a little more proactive in those calls. We're trying to figure out if there anything else that's going on with this patient, really kind of digging into the social determinants of health and being ahead of the curve, that if they are suffering from depression due to the fact that they've been isolated more, or that they maybe ran out of their testing strips and just decided they weren't going to tell anybody. We're trying to dig a little deeper in there, proactively help them be as manage their own medications and their self-management of their diseases as well as they can in the current environment. We've heard from physicians that they find it a challenge to try and do telehealth with a patient who's not used to telehealth, and really getting the story about where they are with their chronic diseases, diabetes being a great example of one. So I think the key is think about what those needs might be and don't be afraid to reach out ahead of time. Don't wait for the patient to call you.
Yeah, I think that's such a great tip and a great pointer for all of us, that with our seniors who may be experiencing a lot of isolation and are experiencing fear, being proactive in our outreach and communication to seniors is probably going to be more important than it's ever been in order to ensure that they get appropriate care. Carrie, I want to ask you about, as a consultant pharmacist, has COVID impacted the way that you do your monthly chart reviews? And are there waivers in place that allow you to do things differently as a consultant pharmacist under COVID? Tell us just a little bit about what's different there than it used to be.
Well, it is different because I'm not physically going into the facilities. And one of the things I used to spend a lot of time doing was physically trying to track down that hard copy chart to put my signature and date on. And so I used to spend a lot of time doing that. And I have, as a preceptor, I've got students running around trying to find charts for me that, maybe it's a new admission. And because I'm not physically having to track down that chart, as a positive, the silver lining in all of this is I feel like I can dig a little deeper clinically when I'm doing my chart reviews, because I'm not having to run around and look for the charts. I'm able to look at everything digitally and spend a little more time really looking at drug interactions and duplications and things like that to provide the best recommendations to my facilities and the best pharmaceutical care to these patients. So there is a silver lining in the sense that I can be a little more efficient in my chart reviews. There were some emergency orders put in place in the state of Alabama that allowed for us to do that, to do everything remotely. And so we are not physically signing charts right now. And I'm not sure that we'll go back to that. So it'll be interesting to see in the post-COVID days if we go back to physically signing charts.
Yeah, I think that's been a conversation we've had every week on this program. Is healthcare is probably not going to be the same as it was prior to COVID, and that's probably just one example of a change that's happening. Now, Matt, I want to dive into a specific patient population. I want to talk about COPD patients for just a moment. There's been a a lot said about the nature of COVID-19 being spread through aerosolized droplets. And I understand in some previous conversations I had with you that that's actually played itself out in the nursing home with some medications. Could you tell us a little bit about that?
Yeah, so when you think about a senior patient who's got COPD and the the decreased lung volume they've got already, the use of a metered dose inhaler is not typically the way you want to go to really deliver drug to those patients. So nebulized medications are pretty much a standard for a patient at that age and at that point in their life with COPD. Well, both the CDC, the Department of Health have looked at that, and their fear is that if one of these patients has COVID, hasn't been diagnosed, not maybe showing a lot of extra symptoms because of it, their nebulized aerosol could spread that to either the caregivers, the nursing home staff, to another patient who's in that same room. And so they've really tried to thwart those down to an absolute necessary patients that have no other course of action other than to use a nebulizer, because they're asking staff to do a cleaning and deep cleaning and all that after every treatment. So we're getting orders to switch these people to meter dose inhalers, and what we're trying to do is tell the nursing staff that you're observing this patient. You really need to not only observe how they use it. Is there something we can do in the way of a spacer or another device that's going to help the inhaler be more effective? And a lot of these patients, along with the fact they've got COPD, also have dementia. So training them to use an inhaler might be a daily or a multiple time a day thing, because they're not going to remember what to do. So it certainly can impact therapy. We're monitoring those patients closely. We've had to do some prednisone bursts in some patients that just are not, maintaining under their new medication regimens, and it's a quandary that I can tell you I hadn't even considered as we started to try and take other steps to manage COVID. That all of a sudden that these patients they'd be saying don't use your nebulizer anymore. So kind of a specific problem. Certainly affects a lot of patients of that age group and that are in our facilities.
Well, it's a very practical issue that all of us as pharmacists need to think about, because the public becomes aware of the way the virus is spread, and there may be unrecognized fear that patients in the community have about using nebulizers going forward as a result of this. So very, very practical advice. Carrie, Matt mentioned something that I think I'd like to get your perspectives on, and that is patients with dementia. We realize that a lot of patients who are in the nursing home setting or the long-term care facility have dementia. And, could you speak a little bit to the challenges that you're seeing in the care of patients with dementia and talk about that just for a bit?
Yes, absolutely. That has been a delicate subject that I've been so worried about my dementia patients. It's very hard for us to explain what's going on outside of the doors of our facilities to these patients that are already confused somewhat. And so the real superstars in all of this have been the activities directors in these homes who've tried to keep them in contact with their families. However, it's very confusing for them to look at an iPad and see their daughter, their son, their grandchildren, or see them outside of their window and not understand why they can't come in. So we have seen an increase in behaviors and a decrease in cognition, some depression. So there have definitely been some negative effects of this that have, worsened somewhat dementia, just because they're not seeing their families and their pets. I had a patient this week that was very depressed because he hadn't seen his dog in several weeks, and so we had to make some accommodations to make that happen. And so the real superstars have been the people who have made that happen to try to give them a sense of normalcy. And but it's, I definitely have still continued to make my recommendations. One of the things we have to do as consultant pharmacists is find the lowest effective dose of those psychoactive medications that are sometimes given with the diagnosis of dementia. And I've spent time trying to continue to reduce those doses, but you can imagine it's a challenge to get doctors to attempt those dosage reductions right now.
Yeah.
And Michael, I would just add to that, Michael, I think that that's, it's a case where, here's the federal regulations that are out there about, finding that lowest effective dose, gradual dose reduction. But, as consultants that really understand the patients and the facilities and what's going on around them, it's the time for us to step up and say, now is not the time. Let's see if we can't maintain this. And I think that, you expect it's going to get better down the line, but it is one of those things where, you've got to be realistic about what you can do for a patient, and keeping the patient as the top of your list, and not just thinking that regulations are regulations. We need to make sure we're taking good care of patients.
Right. Well, I tell you what, we're starting to get some questions in from our audience. I think what we'll do is take just a quick break and do a polling question. I'd like to get some of the opinions of our audience here. Our polling question today is, as we're reopening pharmacies, community pharmacies, do you believe that all consumers entering the pharmacy should be required to wear a mask? Do you believe that all consumers entering a pharmacy should be required to wear a mask? Now, I know many of you on the calls in the previous weeks have asked the question about, should we be reopening the front end of our pharmacies? And we know that some are beginning to do that, but we're curious to know what you think about patients wearing masks. We have some confidence about what we're supposed to do, and I'm going to ask Mitch Rotholtz here to join us in just a moment to share some more about that. All right, thank you for responding. Let's look at the results. 93% of you say yes, absolutely, that consumers should be wearing masks as they come into pharmacies. Well, that's good information to have, and how you approach that subject is an important one as we go forward. Now, before we enter into audience questions, I'm going to ask Mitch Rotholtz to join us, and Carrie and Matt, if you can mute your cameras, we'll have you join us back in just a minute. Mitch is going to share some new news with us from the CDC. Mitch?
Oh, thanks, Michael. So when we finished last week's webinar, you recall we talked about the upcoming CDC revised guidances that we were expecting out. Well, one part of the guidances actually got released right after we finished our webinar, and so we posted that and put it out there. But I'm going to go through what's in that just to kind of make sure our folks are aware of the changes in some guidances. We are still awaiting the guidance related to vaccinations, which to me is the second part of the pharmacy guidance that we're still waiting for definitive guidance in terms of implementing or reintroducing vaccinations into pharmacy practice. So in the guidance for pharmacy practice, there are a couple of things that I want to bring to your attention. Providing clinical services, when you have an interaction with the patient, begin to start having those interactions just like you had before COVID, assessing the patient, making the recommendation, and if you and the patient are comfortable doing the vaccination, and it's the benefit versus the risk part of the discussion is that the patient should get vaccinated, go ahead and vaccinate. And vaccinate with precautions in place given what's going on in your community. And so one piece of advice we're given is that look and see what other providers, what other medical offices and clinics and public health are doing in regards to their interactions with patients. So as was just talked about in face coverings, the guidance to pharmacy talks about everyone entering a pharmacy should wear a face covering. And so it could be a cloth mask, but they should have a face covering. In terms of pharmacy and pharmacy staff, medical or surgical face mask is appropriate. Now, depending upon what's going on with COVID in your community and what other providers like medical offices like I talked about are doing, you might need to consider utilizing an N95, but that's based on what's going on in your community. In addition, it's not a requirement, but it's an option, again, based on what's going on in your community. If you want to or are comfortable utilizing eye protection, that's also appropriate as well. Also, focus on priority patient populations. So, for example, people who are at risk of COVID are some of your primary targeted populations. So, the theme of this webinar this week are older adults. I would also say adults with underlying conditions, cardiac patients, respiratory patients, are ones you should do specific targeted outreaches to talk to them about the importance of them being up to date on their immunizations as we approach having a COVID vaccine available. So as influenza season is coming forward, you want everybody to be prepared to get vaccinated when the vaccine becomes available. The other nuance in the guidance is that you should screen patients for fever. So that's something different that we've seen in the past, but you should screen. So to do a temperature check and do some pre-screening of patients in terms of how they're feeling and if they have a fever. And then before vaccinating, good hand hygiene. So wearing gloves, changing your gloves in between patients, and washing your hands. Those are the key points that were in the revised pharmacy guidance. And again, as I said, we're waiting on the more specific guidance related to vaccinations that will apply to pharmacy as well as all immunization providers.
Mitch, thank you for sharing that information. That's very helpful. We are appreciative of that. I'm going to ask Matt and Carrie to come back on with your videos. I want to actually ask Rhonda Battle, one of our participants today, has a question about offsite vaccination clinics, and Mitch touched on it a little bit, but I want to hear Matt's perspective on how he intends to approach this. So, Rhonda, your line is open. We'd love to have you ask your question.
Yes, can you hear me?
Yes, we can.
Wonderful. I was just wondering if there was any guidance or tips for when we're doing the off-site vaccination clinics, like at the retirement homes, this flu season, especially with the physical distancing. I know you're saying pharmacy staff may want to use the N95, but what other tips do you have for us?
Matt, what are your suggestions in your practice?
So we've been discussing this full bore the last few days, and I think a couple things that we've talked about. One is think about getting consent forms to patients ahead of time. Either if you have an electronic ability to do that, and an electronic ability to have them send them back in a HIPAA compliant way, that'd be great. But even if you're not doing that, get them so they're filling out the claim form someplace by themselves and not joining into a crowd where everyone's trying to sit down and fill them out. The second thing is we are planning on, instead of just saying, the flu clinic at this facility is going to be from 11 to 1:30 or 11 to 12:30, we're going to try scheduling patients into slots. And so probably schedule them 2 patients at a time in 5 or 7 minute slots. So it's, it's probably going to take a little longer than it used to because people aren't always going to show up when you expect them to, and people are going to go back to their rooms and not be where they're supposed to be at the time. So you have to be aware of that. So they might not be quite as efficient. But I think working with the facility to make sure that they understand things are going to be differently, and really scheduling as much as you can schedule, doing as much pre-work as you can do, I think are the things we're looking at. We've got some that are like schools where we do teachers that, has always been just kind of a random who shows up when, and sometimes there's 25 people there at once, and sometimes there's 2, and so we know that that's not the way we ought to approach it this year, and we're actually looking into a system that allows that electronic back and forth of the consents. Just talked about that earlier this week. So I would take what Mitch said about a little more precautions on the PPE as you go into that spot, and then secondly, schedule as much as you can.
That's great. Good tip. Mitch, do you have anything to add to that?
Yeah, great points, Matt, and thanks for bringing those forth. The other thing I would add to it is think about, especially for your elderly patients, seating. If they have to sit, what's going to be any distance? So you may get there early for an appointment. Are they going to not be able to stand? And making sure you've got seating that's spaced enough that they're not on top of each other. Second, if you're going to do anything that's got any kind of big group, which is not really recommended at this point, but make sure you've got markings on the floor to where people, and that if you're going to have any kind of lines, again, they'd like you to avoid lines, but if you are, and they're going to wind it anyway, do not have them winding up right next to each other. So think about that from a distance, but I think Matt's strategy is very appropriate for this time and starting to at least get the wheels going of doing these clinics.
All right, great. I'm going to ask the staff to unmute the line of Kelly Fine. Kelly's got a question that really goes, I think, to Carrie about long-term care, and I think you touched on this a little bit, but it's a good point to reconsider. Kelly, would you please ask your question?
Yeah, I was wondering in the long-term care setting if you have been initiating deprescribing efforts to decrease risk of exposure.
Sorry,
Did you hear the question?
Question, Carrie, is have you been initiating deprescribing efforts of unnecessary medicines to try to decrease risk of exposure? What are you doing with that?
Absolutely. I've definitely been trying to simplify drug regimens. My goal has been to simplify drug regimens to reduce the number of times that the nurse administering medications has to come in contact with the patient. And we should really be doing that most of the time anyway. But in the sense of a great example is sliding scale insulin. Instead of 4 times a day going in and checking blood sugars and giving sliding scale, we already know that that's on the Beers criteria. It's a high risk way of controlling blood glucose. This is a great opportunity for those patients to be converted over to a basal bolus dose of once a day, and it provides better control. It reduces, finger sticks and injections. It reduces supplies and nursing administration time. So I've really been trying to do some things like that so that there's not quite so much nursing time to administer medications. So I'm certainly getting rid of medications that I deem unnecessary, but I do that anyway. So some of that hasn't changed, but I've really used this as an opportunity to really kind of help encourage basal bolus doses of insulins, and trying to use something like a longer acting nebulizer treatment instead of duo nubs, 4 times a day or 6 times a day. I'm trying to use some of the longer acting agents so that we can do those fewer times a day. So great question. Thank you.
Good. Let's unmute the line
Michael?
of Starlin Hayden Grading. Starlin has a question that I'd like to get Matt to respond to as a community pharmacist practitioner. Starlin, your line is unmuted. Let me ask the question for Starlin. I think this is a great question, Matt. How do you feel about having parking lot curbside administration of flu shots versus having people come into the pharmacy? Have you given any thought about helping to maintain social distancing by really going to the patient rather than having the patient come inside to you? What are your thoughts on that, Matt?
Well, we do that. We've done that for several years on a sporadic basis, Michael, for people that just don't have the mobility, or mobility is such a challenge for them that we've done it before. It's certainly not my favorite way to take care of patients. Just kind of like a drive-up window is not my favorite way to counsel patients, but we're doing a lot of it right now. But we talked about that as part of our plan of attack, that we will probably do more of that this flu season on patients that either feel that their risk is high enough that they don't want to come in, or if we feel their risk is high enough to everybody else around them that they shouldn't come in. So, I think problematic is, that we like to have people hang around a little bit after they do a flu shot, make sure they don't have an untoward reaction. If they're in their car and we're going to go out and do it, and then, we're going to move on to our next thing, it makes it a little more challenging. But, truth be told, people don't like to stay around in the pharmacy after they get their vaccines either. So it's, it just may be a little more challenging from that aspect. But we've done it in the past, and it's doable from a, as far as injection targeting and everything like that. So my guess is we'll do more of it this year. It still wouldn't be my favorite way to take care of patients.
Well, thank you for the answers to those questions. Matt and Carrie, we're going to let you mute your cameras. And, these are live broadcasts that are brought to you from APhA Live, and things are changing rapidly in the COVID environment. And I just got a note that the CDC has some late-breaking information that has occurred just during our call. Mitch Rothholtz, I'm going to call on you to share what that information is that pharmacists need to be aware of.
Okay, and I'll touch on one thing about that Matt said in terms of the curbside, because this also impacts what I'm going to tell you guys too, is that we've asked CDC for more guidance on curbside and outside practice facilities, because again, if you're doing it in the car, as Matt said, you should have a patient waiting post-vaccination, as well as making sure you're doing the right injection technique so you don't have a server concern in the injection. So we're waiting on some more clarity from CDC and guidance. So in terms of guidance, I want to give you guys an update. I talked about the vaccine guidance update, and we've been in constant communication with CDC. And while we're on this webinar, we've got an update on that the adult schedule is still in clearance. The original language on the page, if you recall, it had in there language about postpone. That page has actually been taken down. So it'll give you a little insight in terms of what the revisions will probably be addressing. But they took it down because it had the word postpone in there. So the intent is not to have providers postpone vaccinations, but have the discussions and move forward. So I wanted to confirm what some people were asking questions about over the last 2 weeks. Some people have seen that page go down, and we wanted to confirm what was going on. And so that's the latest. Guidance is in clearance. As soon as that's released, we'll release it out to everybody when we get it. And that the original guidance language was taken down because it had the words postpone in there. And so that'll give you some insight in terms of the direction of revisions.
Well, that's great. And I'm going to ask Diana Fadley, who is a Hawaiian pharmacist, to ask her question, which is very directly related to the information you just shared. Diana, would you please ask your question? I think the staff has unmuted your line.
Okay, I'm here.
We can hear you. Go ahead.
So we haven't had any active COVID cases for over 2 months now, and particularly on our island. And no one's been able to come or go without having to self-quarantine for 14 days. So I feel like we're in pretty good shape to resume our vaccinations. What are your thoughts on that?
Yeah, Mitch,
great question, Diana. Thank you for asking the question. I would go with the guidance that your public health departments are doing for all providers. In the case you described, this is my personal perspective, I wouldn't hesitate giving vaccinations. Again, still use protection, still have the mask and gloves and follow those, but I wouldn't have a fear. Again, the ability to do vaccines and offering the vaccines is a comfort level between the provider and the patient who's receiving it. So that's part of the discussion that needs to occur between the parties. But again, if you need something to use as a guide, use your public health department's guidance and recommendations. And again, as the CDC guidance says, based on what's going on in your local environment, that should be your guide.
Okay. I'm going to ask Dan Zlott, our clinical expert, to join us here for the next question. I think this question is really beyond vaccination. Let's talk just about some terminology that's being used during the COVID outbreak. The term moderate to substantial community transmission is language that's used in lots of documents, and when we're trying to make decisions about, do we open, do we not, do we provide this service, do we not, what does this terminology mean? Is there any real definition to moderate to substantial community transmission, Dan? What's your understanding of all of that?
That's a great question, and I will see if Mitch wants to weigh in as well on this one. In the reading that I've been doing and the research that I've been doing, it's fairly fluid, and I think there's a lot of interpretation based on local communities, local counties, local state departments of health, and so I have not, at least so far in my readings, found a really solid formal definition of moderate to severe transmission and what that means. I think each locality is sort of making some of those determinations on their own. Mitch, do you have any other insights on that?
Dan, I would agree with you. It's really, as we've heard in discussions with CDC and working on guidances, it's really what your local public health department is saying in terms of even classifying the zone, the red, yellow, and green status of your area, and that's what I would use as my guide. But you're absolutely right. There hasn't been a good definition that I've seen yet on that.
Yeah. Okay, Dan, while I've got you on the line, I want to ask you one more clinical question, and that is, we received a question in advance of today's webinar about antibody testing. And are you aware of antibody testing that might be happening now in community pharmacies, what that might be looking like, and again, remind us of any key takeaways that pharmacists need to know about antibody testing in community pharmacies?
Absolutely. Also, another question that we get frequently, and I will also invite Elisa to jump in case I miss anything. But a couple of different things. One of the first things is that for any test, we're looking for FDA authorization, the emergency use authorization. And so particularly with antibody tests, there are a tremendous number of tests floating around out there that have not received FDA approval. So it's incredibly important to check the FDA website for tests that have gone through a little bit more scrutiny in that emergency use authorization process. So that's probably going to be the key takeaway in terms of what you want to look for. Other things just in general about testing, understand the sensitivity and specificity of your tests, and that is the true positive and false negative rates of your tests. And so just understand sort of the implications of those. And one of the issues, of course, with the non-approved tests is that oftentimes they have variable sensitivities and specificities from lot to lot. There's not as tight in terms of quality control, and then they may have unacceptably low sensitivities and specificities. So a little bit of a broad answer. There are a number of antibody tests in particular that I believe are in the process of being approved for pharmacy use, and those potentially could be great point of care tests. The other thing to point out about antibody-based tests is that a number of pharmacies have gone the route of partnering with lab corporations who may be able to take a specimen and do a little bit more advanced analysis of some of those specimens. And so that might be another option as well while we're waiting for fully approved point of care tests for antibody testing. Elisa, anything else you'd like to add?
No, I think you covered it. That was great. Thank you.
Great. All right. Well, I want to share. I share an experience. We had had one of our pharmacists, Kimberly Crowley from Kentucky, who wanted to share her experience, not a question, but she doesn't have a microphone, so I'm going to share it with you. She says that every skilled nursing facility in Kentucky is required to test every patient and employee on the same day. We're scheduled for June 12th to test via nasopharyngeal swab, and she, as a pharmacist, is helping to conduct those tests. They've had no COVID-19 tests. They're prayerful that no asymptomatic person shows up in this set of testing, because that would set off a lot of other things, and of course that's true. But I will tell you that, Kimberly, you are a great example of a pharmacist working the front lines, taking care of patients in your community and doing exactly what we know pharmacists are stepping up to do day in and day out, providing excellent care. So I commend you to that and for that. And we know that there are countless pharmacists out there who are stepping up and doing similar things. Now, I'd like to share with you all a few bits of information, very important information that we don't want you to miss this week. First of all, as you all know, we have an educational series that provides continuing education called APHA's 15 on COVID-19. And these are 15 to 20-minute segments that are available for CE credit so that you can get CE. And in the last couple weeks, there have been some information, last week actually, new episodes posted on late-breaking information related to hydroxychloroquine, which we all know has been all over the news and has been the subject of a lot of conversation. So I would commend those to your reading and listening because they're great and a simple way to get 15 minutes of CE. There are 19 episodes of that now, so quite a lot of opportunity there for you as well. And then I also wanted to share with you that there are quite a number of practice resources that have been added to the COVID-19 webpage at pharmacists.com, including just yesterday a brand new information on telehealth in your pharmacy practice. Now, I'm going to let the cat out of the bag just a little bit here because next week we're going to spend our entire webinar talking about telehealth in pharmacy practice and some transformational things that are underway and happening as it relates to pharmacists' engagement in telehealth. And you're not going to want to miss next week's show, but you can prime yourself by taking a look at pharmacists.com and reading this practice resource that's been posted. There's also a practice resource on the vaccines that are under development for COVID-19. And the most important topic to pharmacists everywhere is PPE during the pandemic. And so very important, and we add resources to this page every single week. Now with that, I want to call on Elisa Bernstein to join us. She's going to share a couple of bits of information regarding activity this last week with CMS. Elisa?
Thanks, Michael. So I'm going to give you a little bit of update on some activity from this week. Earlier this week, APHA sent a letter to CMS. The letter provided comments on a COVID-19 regulation that they released in April. So CMS has released two regulations, one earlier in April and then another one later in April. These were comments to the first one. We advocated for additions and clarifications related to pharmacist-provided COVID-19 testing, including payment for testing-related services and other pharmacist provider services such as telehealth. Our comments noted the workarounds that CMS has provided that just don't work with our current pharmacy practice and operations, and asked for direct and clear payment pathways. And we also advocated for inclusion of pharmacists in the Medicare telehealth benefit. CMS is working within the limits of the current law, and we've met with them and they've alluded to these limitations. That's why in some cases CMS is really doing backbends to make pharmacist testing payment work. And this is not sustainable. The law must change. We all know that. Pharmacists must be added as providers in the law, and we're working to make that change happen. So an APHA, along with our pharmacy partner organizations, are meeting with and actively advocating for legislation, meeting with congressional staff to provide a direct payment pathway for pharmacist-administered COVID-19 testing, treatments, and vaccines once they're available. And so there'll be more on that, but that's really kind of an area that we're focusing on, particularly this week, of getting some more activity and progress on the Hill with the pharmacy's provider status. We have a call to action ongoing right now. We've talked about this for the last couple of weeks. We're looking for a limit of 10,000, although the slide says 2259 people took action. That's just a reused screenshot. We are close to 10,000 and we need your help. So if you can go to this actioncenter.pharmacist.com and tell Congress that pharmacists can help fight COVID-19 and flu, and it's really easy to send letters using this website. So thank you. Back to you, Michael.
Thank you very much. We appreciate that. And I just want to point out that we have state pharmacy associations across the nation that are working tirelessly at the state level, in addition to the work that Elisa and the team at APhA are doing at the federal level. And I want to commend NASPA and our state pharmacy associations for their good work. Pharmacists, I would recommend to you that you work closely with your state pharmacy associations on the local issues. As you heard today, there are many things related to COVID-19 that are happening locally and that you need to be on top of those, so we'd encourage you to do that. I also want to encourage you to engage with APhA, to post questions on the Engage site at pharmacists.com. Share your lessons learned and support your colleagues. It's a great opportunity for information sharing and for us to network together with our colleagues to be able to solve the issues related to COVID-19. And I also would want to just recommend to all of you, if you're not a member of APhA, please join us. We need you. It's time for us to fight together as a profession to be able to attain provider status and many other things that our profession needs, and your membership matters. And so we would ask that you please take time to go to pharmacist.com and join or renew your membership today. Now, the last comment thing that I would like to talk about today, in addition to next week's webinar, I'd like to end today's webinar. I would be remiss if I did not mention the fact that this has been an extraordinary week in the history of our nation. It is involving the very difficult issues of race and social injustice. The impact on our communities, our colleagues, and our profession has been profound in so many ways. As our new CEO, Scott Knorr, said, this may well be the biggest challenge of our lives. APhA issued a statement on the matter earlier this week, and since then, we have been working very closely with the major pharmacy organizations on a joint statement that will take strong stands against racism, health inequities, and social injustice. We will declare it to be a central concern for us as pharmacists, as healers, and in the joint statement to increase dialogue on this and take intentional action as a profession to address these issues. Please keep an eye out for that joint statement, which I expect is going to be released by the end of this week. To all of you, thank you for joining us today on our weekly webinar. God bless.